To the Kanski lecture series Orbit Part 3, and in this part we are going to study about the infections of the orbit. So there is a pre-septal cellulitis and then there is a bacterial orbital cellulitis. Main difference between them is the orbital septum. The one which is before infection before the orbital septum are called preseptal cellulitis, and the one which is after the orbital septum is called the orbital cellulitis. Preseptal cellulitis introduction. Preseptal cellulitis is an infection of the subcutaneous tissue anterior to the orbital septum. It is considerably more common than orbital cellulitis and though regarded as less serious, and can still be associated with severe complications such as abscess formation, meningitis, and cavernous sinus thrombosis. So there are certain complications that can be associated with it, like abscess formation, meningitis, cavernous sinus thrombosis. Rapid progression to orbital cellulitis may occasionally occur. Organisms typically responsible are Staphylococcus aureus and Streptococcus pyogenes, with causes including skin trauma such as laceration or insect bite, spread from the focal or ocular or periocular infections such as an acute hordeolum, dacryocystitis, conjunctivitis, or sinusitis, and hematogenous spread from the remote infections such as upper respiratory tract or medulla. So there are certain predisposing factors for causing preseptal cellulitis. One is a local and other is a hematogenous spread. Like if a patient is having a chest infection, he also can get the uh, mm, preseptal cellulitis, whereas local are like if a patient is having a sty, if it is having a some kind of trauma or laceration or an insect bite or in dacryocystitis or conjunctivitis, he can also present to you with the preseptal cellulitis. And most common organisms are the streptococcus pyogenes and the staphylococcus aureus. So how are the diagnosis made? The condition manifests with a swollen, often firm, tender red eyelid that may be very severe. However, in contrast to orbital cellulitis, proptosis and chemosis are absent, and visual acuity, pupillary reaction, and ocular motility are unimpaired. The patient is often paraxial. Imaging with MRI or CT is not indicated unless the orbital cellulitis or lead abscess is suspected or if there is a failure to respond to therapy. So, very important is to differentiate between the preseptal cellulitis and orbital cellulitis. So, there will be the eyelid swelling and the lid can be firm and tender, but the orbital cellulitis have a proptosis, chemosis, and can be a defective visual acuity. But in case of preseptal cellulitis, these are all absent. So how do you treat? You would treat it with the systemic antibiotics. Treatment is with oral antibiotics such as co-amoxicillin 250 to 500 milligram per 125 milligram, 2 to 3 times daily, or 875 125 milligram twice daily depending on the severity. Severe infection may require intravenous antibiotics. The patient tetanus status should be ascertained in case following trauma. Visual acuity, pupillary responses, and ocular motilities are unimpaired, and proptosis is absent in preseptal cellulitis. So you can see this is a case of preseptal cellulitis. A is showing preseptal cellulitis resulting from an infected eyelid abrasion. B is showing the axial CT showing a pacification anterior to the orbital septum. So these are all the pacification. Then there is an orbital cellulitis. So orbital cellulitis is a basically more serious condition, and why? Because it can cause the optic nerve dysfunctions. Uh, Bacterial orbital cellulitis is a serious infection of the soft tissue behind the orbital septum, which may be sight threatening and the life threatening as well. It can occur at any age but is more common in children. Streptococcus pneumonia, Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenza are the common causative organisms. with infection originating typically from the paranasal, especially ethmoid sinuses. Infection can also spread from the preseptal cellitis, dacryocystitis, midfacial skin or dental infection can follow trauma, including any form of ocular surgery, blood-borne spread from infection elsewhere in the body may occur. So, very important is that a patient with the sinusitis can develop the orbital cellulitis. And other predisposing factors are the same as for the preseptal cellulitis. So, what will be the clinical features? The symptoms consist of the rapid onset of the pain exacerbated by eye movement. So, there will be the pain on eye movement as well. There will be the swelling of the eye, malaise, and frequently visual impairment and double vision. There is commonly a recent history of a nasal, sinus, or respiratory system symptoms. So, patient may present with the prior symptoms of sinus or respiratory disease. So, what will be the signs? The pyrexia often marked. So, there can be a fever, visual acuity may be reduced, and the color vision impaired, raising the possibility of the optic nerve compression. So, whenever there will be the optic nerve compression, there will be the decrease in the visual acuity, and there can be the RAPD as well. The presence of a relative afferent pupillary defect in a previously normal eye makes this almost certain. Tender, firm erythematous and warm eyelid with periauricular and conjunctival chemosis, edema, conjunctival injection, and sometimes subconjunctival hemorrhage. The signs are usually unilateral, although edema can spread to the contralateral eyelids. Proptosis is common in established infection but is often obscured by lid swelling. It may be non-axial dystopia, particularly if an abscess is present. So, if a proptosis is present, then it is almost certain that it is a orbital cellulitis, and it can be associated with dystopia as well because of the abscess. So, there can be painful ophthalmoplegia. There will be the pain on the eye movements. Choroidal folds and optic diswelling may be present on fundus examination. So, differential diagnosis, major diagnostic alternatives are listed in figure table 4.1. So, these are all the table, and it is showing the different racial diagnosis of an acutely inflamed orbit. It can be due to infection, vascular lesion, it can be tumor, it can be endocrine and non-neoplastic inflammation. So, infection can be orbital cellulitis, fungal orbital infection, infective dacryoadenitis, dacryocystitis. Vascular lesion can be due to hemorrhage. There can be cavernous sinus thrombosis, CCF. Neoplasia can be retinoblastoma, lacrimal gland tumor. Other neoplasm, for example, metastatic lesion with inflammation, lymphoma, Waldenstrom macroglobulinemia, rhabdomyosarcoma, leukemia, lymphangioma, or neuroblastoma in children. So, these are all the orbital conditions that can cause the proptosis and the swelling of the eyelids. Endocrine include the thyroid eye disease of a rapid onset, non-neoplastic contains of an idiopathic orbital inflammatory disease, Tolosa-Hunt syndrome, orbital myositis, acute allergic conjunctivitis with lid swelling, herpes zoster ophthalmicus, herpes simplex skin rash, sarcoidosis, vasculitis, granulomatous with polyangiitis, polyarteritis nodosa, scleritis including posterior scleritis, ruptured dermoid cyst. So, what are the complications of an orbital cellulitis? So, you know that orbital cellulitis is very important for the cases of it can cause the optic neuropathy, and also it can cause the intracranial complications, like it can cause the brain abscess, it can cause even a cavernous sinus thrombosis and even death as well. So, ocular complication include optic neuropathy, exposure keratopathy. So, whenever there is a proptosis, you can understand that there can be optic neuropathy, there can be exposure keratopathy as well. There can be the raised IOP. The orbital cellulitis can lead to endophthalmitis and occlusion of the central retinal artery or vein. Periosteal abscess, most frequently located along the medial orbital wall. Intracranial complications, which are uncommon 3 to 4% but extremely serious, including meningitis, brain abscess, and cavernous sinus thrombosis. Investigation may include ascertainment of tetanus immunization status in cases of trauma, white blood cells count, blood culture, culture of nasal discharge, A high resolution CT of the orbit, sinus, and brain is vital to confirm the diagnosis and exclude a subperiosteal or intracranial abscess. MRI is also sometimes performed. Lumbar puncture if meningeal or cerebral sign develop. So these are all the kinds of the investigation that you can be performed in the case of orbital cellulitis. CT scan and MRI is done to exclude any kind of the brain abscess. So figure 7 or 4.17 showing the right orbital cellulitis with ophthalmoplegia, and axial CT showing both pre-septal and orbital opacification. So this is the opacification. So how will you treat? Now with the treatment, the hospital admission is necessary for case of orbital cellulitis because of the optic nerve compression complication. So hospital admission is mandatory with urgent otolaryngological assessment and frequent ophthalmic review. Pediatric specialist advice should be sought in the management of a child, and low threshold should be adopted for infectious disease specialist consultation. Delineation of the extent of the erythema on the skin using a surgical marker may help in judging progress. So you mark the swelling with the marker, so to know that if the swelling is progressing or reducing. Redness is progressing or reducing. Antibiotics are given intravenously with a specific drug depending on local sensitivities. Ceftazidime is a typical choice, supplemented by oral metronidazole to cover anaerobes. Intravenous antibiotics um, should be continued until the patient has been apyrexial for 4 days, followed by 1 to 3 weeks of oral treatment. So basically you give the patient with the ceftazidime and with the flagyl oral metronidazole, so it can cover the anaerobes. And when if the IV is being started, then it is given until the patient is being feverless for 4 days, and that is followed by the 1 to 3 weeks of the oral antibiotic treatment. So monitoring of the optic nerve function is very important, because if there is a compression, we can produce the surgical intervention. So monitoring of the optic nerve function is performed at least every 4 hours, initially by testing visual acuity, color vision, light brightness appreciation, and pupillary reaction. Deterioration should prompt the consideration of a surgical intervention. Surgery. Drainage of an orbital abscess should be considered at an early stage. Drainage of an infected sinus should be considered if there is a lack of response to antibiotics, or if there is a very severe sinus disease. Biopsy of the inflammatory tissue should be performed for an atypical clinical picture. Severe optic nerve compression may warrant an emergency canthotomy or cantholysis. So whenever there is a very orbital compartment is very tight, then you can perform the canthotomy or cantholysis to relieve the pressure. Because orbital cellulitis often occur as a consequence of a sinus infection, urgent radiological investigation of sinuses is mandatory. So another infection is a rhino-orbital mucormycosis. Very important thing is, with after the rise of the COVID, this was very common disease entity that can be seen in a case of a diabetic patient who were given steroids in the COVID. So rhino-orbital mucormycosis, it is basically a fungal infection that infect the sinuses and then infect the orbit, and it is a very deadly disease and progress very rapidly, so you have to be very vigilant about that. Introduction. Mucormycosis is a rare, aggressive, and often fatal infection caused by the So, mucormycosis is a rare, aggressive, and often fatal infection caused by a fungi of the family Mucormycosis. It typically affects patients with a diabetic ketoacidosis or immunosuppression, and is extremely rare in the immunocompetent. Infection is acquired by the inhalation of the spores, which give rise to an upper respiratory infection. Spread then occurs to the contagious sinuses and subsequently to the orbit and brain. So first it will infect the sinus and then it will affect the brain and the orbit. Invasion of the blood vessels by the hyphae result in the occlusive vasculitis and with infarction of the orbital tissue. So why it causes the necrosis of the tissue? Because the hyphae, when it invades the blood vessel, it can cause the vasculitis, and that is why it causes the infarction. So how will you diagnose gradual onset of the facial and the periorbital swelling, diplopia and visual loss? Signs are similar to that of bacterial orbital cellitis but tend to be less acute and with slower progression. Infarction superimposed on septic necrosis is responsible for the classic black eschar that may develop on the palate, turbinates, and nasal septum, skin, and eyelids. Complications include retinal vascular occlusion, multiple cranial nerve palsies, and the cerebrovascular occlusion. Differential diagnosis is listed in table 4.1. Investigation is much the same as for the bacterial or orbital cellitis. So these are the necrosis of the eyelid in the rhino-orbital mucormycosis. So correction of the underlying metabolic defect should be instituted if possible. Intravenous antifungal treatment, daily packing and irrigation of the involved areas with antifungal agents. Wide excision of the devitalized and necrotic tissue. Accentration may be required in unresponsive cases in order to reduce the risk of death. Adjunct hyperbaric oxygen may be helpful. So what do you do if you have to remove the, because it's spread rapidly, you have to remove any kind of the dead or the necrotic tissue, and with the antifungal, systemic antifungal, these are the mainstay of the treatment. And sometimes when there is a extensive orbital involvement, you have to do the accentration as well. So that's it for the orbit part 3. See you in the next lecture.